Hello and welcome to the first episode of our Blood Cancer Awareness Month special series here on the VJHemOnc podcast. In this episode, we're bringing you a listener Q&A where leading experts in the field answer your questions on CLL, multiple myeloma and lymphoma. Thank you to everyone who submitted questions. This podcast is part of the CLL, myeloma and lymphoma channels on VJHemOnc, which is supported by AbbVie, B1 Medicines, Lilly, Bristol Myers Squibb, Legend Biotech, AstraZeneca, Johnson & Johnson, Takeda and Galapagos. These supporters have no influence over the production of the content. This podcast is intended for healthcare professionals only. Let's begin with Barbara Eichhorst, who addresses your questions on CLL.
Hello everyone, my name is Barbara Eichhorst. I'm a hematologist and consultant at the University Hospital of Cologne in Germany, and we are recording this year for the Ask the Expert session. So one of the questions which was submitted is, considering the progression-free survival benefit of adding ibrutinib to venetoclax obinutuzumab within the CL13 Gaia trial, would you consider using this triple combination in first-line treatment of patients with CLL or specific subgroups? Thank you very much for that question. Arnon Kater from Moritz Wüstenhof presented the data here yesterday, and indeed there is a 12% difference by adding ibrutinib now after more than 5 years observation time in comparison to venetoclax obinutuzumab only. However, the reason why I still wouldn't use it in clinical practice is that on the first hand, we don't see a difference in the overall survival. And we also see, on the other hand, more toxicities. We see more infections with the triple combination, more cardiac comorbidities. And also when we look at quality of life, we see at least that during the treatment, patients' health-related quality of life is improving only when patients finish the triple treatment. I think a subgroup which may benefit from that, but they were excluded from the Gaia trial, are patients with TP53 aberration, the lesion 17p. We did a phase 2 trial on those patients also showing promising results. I think this may be justified in this group of patients to use the regimen. Otherwise, even in patients with unmutated IDH3 status, that's where we saw most of the benefit of the triplet treatment. And considering that many of them still have a very good prognosis, I would still not use it from the beginning. The only subgroup which may benefit are patients with high complex karyotype, where we have seen that the triplet is working here very effectively. And even patients with venetoclax obinutuzumab do have a shorter PFS when they have 5 or more chromosomal aberrations. So the next question is coming from Dr. Wang from the Mayo Clinic, and he says he's curious to know thoughts on the acalabrutinib venetoclax or acalabrutinib venetoclax obinutuzumab frontline CLL therapies, when to use these regimens as opposed to venetoclax obinutuzumab or BTKI continuous treatment. Very excellent question, difficult to answer because we are waiting here for study results for the comparison of continuous BTKI versus double oral therapy. We're waiting for the results from the CL17 trial comparing venetoclax ibrutinib versus ibrutinib. We will have the results end of the year. And for VG venetoclax obinutuzumab versus AV, the MAGIC study from the Dana-Farber Cancer Institute, fully recruited fast, and also here we are waiting for the results. But obviously the advantage of the acalabrutinib venetoclax is it's much more convenient for the patients than CD20 antibody infusions. On the other hand, when we have young patients with respect who wish to have very long-lasting remissions, MRD rates with acalabrutinib plus venetoclax were relatively low, particularly low in comparison to venetoclax obinutuzumab, and seem to be, if you would like to do a cross-trial comparison, also a little bit lower than ibrutinib venetoclax. Therefore, though in the Amplify study evaluating acalabrutinib venetoclax, more fit patients were included, but I personally would consider acalabrutinib venetoclax more in an unfit elderly patient population for whom it is not so convenient to come for the obinutuzumab infusions frequently to the clinic. With respect to the triple combination, the AVO combination, certainly due to the relatively high rate of COVID deaths and that treatment arm, but the study recruited during the pandemic, most of the patients, 90%, were not vaccinated before, but still this shows that obviously there's a severe immune suppression with the AVO regimen. On the other hand, we do really see a high efficacy with the triplet regimen and, for example, patients with TP53 aberration, so they were excluded from this trial, could be candidates for using this triplet combination. We are currently investigating that in the CL16 trial. The next question is from Dr. Carrie Rogers from Ohio State. She's asking, with 2 fixed duration options now available for frontline CLL, venetoclax obinutuzumab or BTK inhibitor venetoclax, how do you decide between those 2 treatment options? Which patient groups do you favor for one over the other? Yeah, so when we look at the 2 subgroups of patients with mutated and unmutated IDH3 status, we do see that in particular patients with a mutated IDH3 status have very long progression-free survival rates. In the CL14 trial for the elderly patients, after 6 years, 75% around of the patients are still without a relapse. And also now in the Gaia CL13 trial, after 5 years, 80% of the patients in this subgroup are without a relapse. Therefore, I personally think, again, doing cross-trial comparisons, since we do not have the head-to-head comparison, and that these patients in particular benefit from the CD20 antibody plus venetoclax. For the unmutated patients, I think it really depends. It's hard to tell. It could be that patients with lymphadenopathy benefit more from the combination of the BTK inhibitor plus BCL2 inhibitor, for example, and I would discuss that with the patients in the absence yet of data from the head-to-head comparison, how convenient it is for the patient to come to the clinic, having the controls, and then finally also considering the immunosuppressive effect of the CD20 antibody. In case the patient had a history of several infections, severe infections, I would consider this patient rather for the double oral combination than administering a CD20 antibody. The next question, also from Carrie Rogers, is while the data is still developing, what second-line options do you think will be best after initial therapy with BTK inhibitor venetoclax combination? Yeah, that's a very difficult but important question because that's, of course, what patients are asking for. So from the Captivate trial here at the EHA study, we have now with a new update and data being presented on 36 patients receiving relapse treatment, 24 of them around receiving a continuous treatment with ibrutinib, and 12 or so with the combination of ibrutinib plus venetoclax. The response was quite good in those patients. So in 2 of those patients now BCL2 mutation, which has not yet been reported, which is not yet known that this is really resulting in resistance. So obviously that's a big disadvantage on the double oral combinations that we have a lack of data here for the relapse treatment options and how effectively patients respond. However, at least for venetoclax obinutuzumab, we don't see BCL2 mutations in relapse situation, at least at the last data cutoff already a few years ago. In general, I would suggest we will not see many patients becoming refractory with this time-limited treatment, but certainly this is a risk where we have to inform patients about. And then another question is, which patients do you think are best treated with continuous BTKI monotherapy? According, for example, to the ESMO guidelines, this would still be the first treatment of preference for patients with TP53 mutation or deletion 17p, since it seems that progression-free survival rate, when we compare those across the clinical trials, is still better with the continuous treatment with the BTK inhibitors. That is the one group. The other one, which may be considered, are patients of older age for whom it is really difficult to come frequently to the physician's office, that they may benefit, for example, from continuous treatment with the second generation of BTK inhibitors for having good disease control, but do not necessarily achieve undetectable MRD rates.
Next, we'll hear from Rakesh Popat, who provides insights into multiple myeloma and tackles the questions you've sent in.
My name is Rakesh Popat, and I'm a haematologist based at University College Hospital in London in the UK. Thank you guys so much for sending in your questions. Got some really interesting topics to discuss. Not sure I know all the answers, but they're certainly really pertinent questions for a conversation. So let's kick off with the first question. This is from Mustafa, Clinical Director at MedStar. Thank you so much for this question. What would be your treatment for a solitary plasmacytoma patient who has residual metabolic activity after radiation therapy? Now, this is a really, really interesting and clinically relevant question because we do see this quite often in this situation. So let me just backtrack a little bit and put a bit of background in. The management for a patient with solitary plasmacytoma is with radical radiotherapy, and we anticipate that a good proportion of these patients will be cured. Now, having said that, we do need to monitor these patients clearly following the radiation therapy, looking out for relapse. Typically, when the relapse occurs, it is actually often not at that site that was irradiated because the irradiation field is quite broad. And secondly, the radical dose of radiotherapy is very high and extensive. So actually, when people relapse following the solitary plasmacytoma, it is in a different part of the skeleton. So in terms of how you manage these patients, you do need to be monitoring with whole body imaging modalities. You can take your pick, whether you do CT PET scans or whole body MRI. For extramedullary plasmacytomas, the modality of choice would indeed be CT PET. But in direct answering your question, is that you need to be very careful with acting on a scan that has residual FDG activity, particularly early on following radical radiotherapy, because it can take months and sometimes over a year for it to resolve. So the first point is, if you do see residual FDG activity, I would continue to monitor. And you do regular scans, and then you see where things are following 12 months. If you still have residual activity over 12 months, I would continue to perform active surveillance. There is no indication to commence systemic treatment simply because of residual activity. The reason to start systemic treatment is if the patient then goes on and develops the features of myeloma, i.e. they develop either SLIM or CRAB criteria. And what you need to be doing at that point is monitoring very closely, both in terms of blood, urine, and whole body MRI assessments. So I hope that answers your question, Mustafa. Super interesting question. And we'll move on to question number 2. This is from Marielle Fragner Salimbi, who is based in Brazil. So fantastic question from Brazil. When could patients with multiple myeloma after initial treatment potentially practice physical activities like soccer? Thank you so much for your question. This is a question that patients ask us day in, day out of clinic. It's such a relevant question for the myeloma community. All right. So to answer your question, it's not straightforward is the answer. What you need to do is to assess the bone structural elements of the patient. So typically you would do a whole body CT scan. Either you would do a whole body low dose CT. Maybe that's what you do in Brazil, or you might do a whole body PET CT scan. The reason why the CT component is very important here is because it assesses the structural integrity of the bone, and it's far better than an MRI in this setting. So what you need to do is that you have your baseline CT scan, and then you perform a follow-up scan after you've finished treatment. And then that will guide you as to what level of physical activity that the patient can do. It is most likely that a patient could do something like soccer because soccer is more of a low impact activity. What you worry about more is, particularly with people with spinal disease, is twisting movements. So, for example, golf is a problem because of the twisting of the spine that happens. And other high impact activities such as contact sports, maybe rugby, maybe American football, maybe things like bungee jumping, abseiling, which are more kind of high impact activities. You need to be a little bit more careful. Cycling, for example, is normally something that you could do, but you might want to be a little bit careful and slowly build that up. My recommendation is that you have input from either your orthopedic team or your spinal team to guide in terms of the absolute answer. And then the final point is about physiotherapy. So for these patients, and I'm assuming that this is presumably a younger and more active patient who wants to return to soccer, physiotherapy input early on is incredibly important. to allow that patient to return to physical activity. Because what we do know is that physical activity is good in terms of the long-term survival of the patients. So again, thank you for that very relevant question. I'm now going to move over to Turkey, and Meral Beksak, thank you so much for sending this question in from Ankara University. In your daily practice, do you defer autologous stem cell transplants for newly diagnosed myeloma patients? And if yes, how do you decide? Meral, this is a spot-on question and right on exactly what we're discussing currently, day in, day out, for myeloma patients. In my personal practice, I do not defer autologous stem cell transplants. In the UK, we offer a stem cell transplant for all younger, fitter patients, and we would not defer those patients. However, there are a small proportion of patients who do not wish to proceed to a transplant because they do not want to undergo the toxicity for that. And so I think in those cases, it would be reasonable to do that as long as you have stem cells stored. But perhaps answering your question more broadly, the question relates to what data we have so far. All the data that we have, both from the UK Cardamom study, the IFM study, and more recently the Dana-Farber study called Determination, all of those data suggest that stem cell transplantation continues to remain superior according to standard treatment. The only study that was just reported at ASCO that puts this into doubt is the MIDAS study. And the MIDAS study, as you know, used isatuximab KRD, which is not standard treatment, and they had very high levels of MRD negativity. And I think what that shows you is that if you are MRD negative following induction treatment, that may be the one group of patients who you could stop treatment. So I think if you were MRD negative post-induction and if you were standard risk, that would be the one group of patients who I would defer transplant to. So again, thank you so much for that question. And Meral, you've asked another question. Fantastic. How do you decide to stop maintenance therapy? Again, this is such a hot topic. And I assume, Meral, that you're talking about lenalidomide maintenance following autologous stem cell transplant in terms of that question. So again, the clear answer is we don't know because we don't have prospective studies to give this answer. But there is some very interesting retrospective data to that. The first piece of real-world evidence I would put forward is that we know in terms of real-world evidence that patients will naturally stop lenalidomide maintenance around 2 to 3 year mark, normally because of intolerance. So that's typically what we're seeing. But what does the clinical trial data show? Well, my colleague Charlotte Paulin from the UK did some retrospective analysis from myeloma 11. And what we looked at was to look at the benefit of ongoing treatment at 1 year, 2 years, 3 years, 4 years, 5 years, and 6 years. Now, of course, there is some bias built into that because it's to do with how well patients are responding. But what she suggested was that once you hit the 3 year plus mark, the added benefit of ongoing lenalidomide maintenance is marginal. And so I think if you're going to stop treatment, if you're in CR, potentially MRD negative at 3 years, that would be the time to think about stopping. There is some collaborative data from the Greek group who did a prospective study, and that shows very similar data. So I would put to you around about the 3 or 4 year mark would be the time to stop maintenance therapy. The only population that you'd be worried about is the high-risk population or the ultra-high-risk population. And it may be that those guys have relapsed already by that time and you don't worry about it, but they would probably need to continue treatment. Thank you so much. Very interesting question. And then I think we're down to the last question from Naomi Puk from Salamanca in Spain. Naomi, who is a fantastic world-leading expert in myeloma. Thank you for your question. So you are asking about some of these newer diagnostic modalities where we are monitoring myeloma in the peripheral blood. And you include cell-free DNA, mass spec, and maybe peripheral MRD. And I'd just like to say, Naomi, you're one of the leading experts in this field. And thank you so much for asking my opinion, because we really look to you and Bruno in the Spanish group to be really telling us about this. I think essentially my opinion is, let's start with mass spec. I think mass spec is super important. What mass spec allows you to do is to have a more accurate analysis of the serum M protein in the blood. The reason why this is becoming very important is that we know that serum M proteins, particularly IgGs, have a very long half-life, and it is very difficult to determine complete remission in these patients because of simply the long recirculation of the M protein. And this actually causes lots of problems in clinical trials because of the low levels of MRD negative CR that we assign. But also the second point is that we are commonly using CD38 antibodies such as daratumumab and isatuximab, and these continue to remain positive. And not all of us have access to the frame shift assays, which remove that. And so it's very difficult to assign a CR in this setting. And mass spec being more sensitive will clearly determine those and give you a higher rate of CR. So I truly believe that we need to start moving away from protein electrophoresis and start moving away from immunofixation and start using to mass spec. And there's different techniques that you could use, and it probably doesn't matter which technique you use, but mass spec is likely to be the way to use modalities. But I think the other key point, which you may be leading to, is can we use this in place of bone marrow MRD? And again, the Spanish group is leading the data here. And what we're seeing is that peripheral residual disease monitoring is complementary to bone marrow MRD monitoring. And one of the pieces of feedback that we keep on getting from our patients is that they want an alternative technique to bone marrow biopsies because it's uncomfortable and it's painful. And so I really welcome the work that we're doing on peripheral residual disease, because what it tells us is that we can probably reduce the number of bone marrow samples that we have to do. And we can monitor the patient on a more regular basis using peripheral blood. There are some challenges with the technique, and it is undergoing further optimization, and you need large amounts of blood, but it's certainly a really super interesting technique that we can move forward. And I'd really recommend that we continue to study this prospectively in terms of clinical trials.
And finally, Anna Sureda joins us to share her expertise and answer your questions on lymphoma.
Hello, everybody. My name is Anna Sureda. I am the head of the Clinical Hematology Department at the Catalan Institute of Oncology in Barcelona, Spain. I am also the president of the EBMT. So the first question I have here is, do you think there is a role for autologous stem cell transplantation in patients with large B-cell lymphoma who relapse after CAR-T and respond to a subsequent line of therapy? I think that this is an interesting question, and I'm not so sure if we are going to have a clear answer for that. Autotransplant has been the standard of care in patients with primary refractory or relapsed diffuse large B-cell lymphoma that respond to second-line therapy. And we know that autotransplant can be a curative treatment strategy in this specific setting. With the advent of CAR-Ts in second line, we are not doing autologous stem cell transplantation in these patients, but we know that still around 50% of the patients will fail CAR-Ts. So we have to think which is the best treatment strategy. We are trying in some ways to avoid giving more chemotherapy to the patients, but we have to admit that patients that are failing CAR-T have not really received a lot of chemotherapy before. So we may think that salvage chemotherapy and if response being consolidated with an autologous stem cell transplantation might be a way to go. On the other side, we have many new drugs that have also demonstrated to be effective in this specific setting. And I think that we should be able to generate more data, probably coming from real-world data to better answer this question. But I would think that this might be a treatment option for these patients. So the second question here is, how are you bridging most of your second-line CAR-T-cell patients? This is also another open question. We don't have a standard of care, and we have to take into consideration, first of all, the performance status of the patient. Second, the treatment strategy that the patient had received before, and eventually toxicities of the prior lines of therapies that the patient had received. And third, if the patient has localized relapse or has systemic relapse. The other thing that we have to take into consideration is the availability and the reimbursement of potential new drugs in this specific setting. So I would say that when we have a localized relapse for a patient that is candidate to receive a CAR-T cell therapy, radiotherapy can be a very good option. Radiotherapy is effective treatment. For patients with localized disease, we have to expect less toxicity in this specific setting and probably a good response. If we have systemic relapse, a widespread relapse, of course, radiotherapy is not an option. And here we have to take into consideration the prior treatment that the patient had received and also the treatment options that we have. There are some retrospective analyses that indicate that polatuzumab-containing regimens can be an effective treatment option to bridge these patients into CAR T cells. If we don't have the possibility to use polatuzumab, then we will have to continue with additional or with other salvage treatment strategies that the patient has not received. We have some data, probably not in the second-line setting, but in later lines of therapy, where bridging patients with bispecific monoclonal antibody can also be an option. But of course, in many places, we don't have the possibility to use bispecific monoclonal antibodies, and this remains, I would say, an area of future research. So, the next question is, how are you selecting patients for third-line CAR T or third-line bispecific monoclonal antibodies? So I think that this question probably, at least in our setting, was more relevant a few months ago or a while ago because we didn't have the possibility to use CAR Ts in second line. Nowadays, we have CAR Ts in second line, and probably outside prospective clinical trials, patients that relapse after CAR T second line, we would consider bispecific monoclonal antibodies in them. When we were using CAR Ts in third line, I have to say that the possibility to use bispecifics in a third line or plus was not an option, at least in Spain. Nowadays, we have these two possibilities, and let's say the decision of using CAR Ts or bispecifics, from my point of view, is kind of relying on the profile of the patient. If we have patients with rapidly evolving disease, with very aggressive disease, probably these patients would eventually benefit more from having an off-the-shelf treatment such as bispecifics that will be able to eventually control the disease progression in a quicker period of time. If the patient has relapse disease, but we think that the disease can be controlled during this period of time where we are collecting the lymphocytes and we are manufacturing CAR T. We have more consolidated data even in third line with CAR T in front of bispecific. And of course, if the institution, the center of the patient has the possibility to receive CAR T, maybe that should be the treatment option. Of course, in this decision-making process, we have to take into consideration the accessibility of the patient to CAR T, which is not the case in many centers and in many areas around the world. So I would say that if CAR T cells are not available, bispecific could represent an excellent treatment option for these patients. So, and I have the last question here. What advice would you give early career physicians who want to specialize in transplant and cellular therapy? So first of all, I would like to encourage all young physicians to demonstrate interest and to go into the transplant and cellular therapy field in hematology, which is basically what I have done for many, many years. It's nowadays really a moving field with many new developments, with the possibility to use new treatment strategies that we were not able to have in the past. So I think that from a scientific point of view, it's really challenging and it's an area of highly scientific interest. I think that we have to be really very proactive here. We have to work on educational strategies. So you need to, let's say, to work on educational programs to be as much proficient as possible in this specific field. And of course, you have to be really encouraged. You need to find good mentors, basically, to make it happen. Thank you very much for your attention.
Thanks so much for listening to today's episode of the VJHemOnc podcast. Stay tuned for episode 2 of this Blood Cancer Awareness Month special series, coming soon. Be sure to follow us on X at VJHemOnc and subscribe to our podcasts on Spotify, Apple or Podbean. Until next time.